Hi, everyone. Thanks for joining me for ACEP's Capital Minute, a look at what's happening in Washington right now that's affecting emergency physicians and patients. I'm Laura Wooster. For the next 30 or so minutes, I'll give you an update of what's happening in our nation's capital, and then we'll open it up for questions. You can submit them at any time by using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live after my update. So today, we'll cover a legislative update on physician mental health, the X waiver, psychiatric boarding, and more, the status of the COVID relief package, regulatory activity, including administration appointments and next steps on preventing ED violence, and the latest on CDC guidelines for vaccination. A flurry of legislative activity has significant implications for emergency physicians and patients. You can be proud of several bills that ACEP was able to secure reintroduction of in the last couple of weeks that advance our priorities. Let's take a look. ACEP strongly supports the Workplace Violence Prevention for Healthcare and Social Service Workers Act of 2021, which was introduced last week in the House of Representatives. This bipartisan legislation directs the Occupational Safety and Health Administration, or OSHA, to issue standards for employers to implement on workplace violence prevention plans to protect healthcare and social service workers from assaults. ACEP actually worked with the bill drafters in the previous Congress to include language that addresses some of the unique aspects of a hospital environment. Now, we've made it a priority to let your voice be heard on this important issue. All ACEP members are being urged to contact their representatives in Congress to support the passage of this bill through our new Advocacy Action Center that you can be found on acep.org under the Advocacy tab at the top of the screen. As well, if you'd like to publicly share your story about workplace violence to help advance our advocacy, please contact pr@acep.org. We look forward to helping see this important legislation signed into law. Legislation that ACEP worked to draft last year, the Dr. Lorna Breen Healthcare Provider Protection Act, was reintroduced in the U.S. Senate last week by Senators Tim Kaine of Virginia, Todd Young of Indiana, Jack Reed of Rhode Island, and Bill Cassidy of Louisiana. As you know, it's named in honor of one of your emergency physician colleagues in New York City, Dr. Lorna Breen, who died by suicide last April after being overwhelmed by COVID-19. Among other things, the legislation would create training grants to help prepare students, residents, and others to help reduce or prevent suicide, burnout, and substance use disorders, conduct an education and awareness campaign encouraging healthcare professionals to seek mental health support and treatment if needed, establish grants for employee education, peer support programs, and mental or behavioral health treatments, and commission a study examining provider mental health burnout and identifying barriers to seeking care. While the current COVID relief package already contains funding for some of these programs, this authorizing legislation would be complementary and provide more specific guidance on how these grants should be distributed and overseen, as well as establish the study on barriers to seeking mental health support services for physicians and other healthcare providers. A bipartisan companion bill in the House was also introduced this week and is sponsored by Representatives Susan Wild, David McKinley, Raja Krishnamurthy, Fred Upton, Judy Hsu, Morgan Griffith, Haley Stevens, and John Katko. You can expect an action alert in your inbox on this bill as well. If you are subscribed to our weekly updates, you will receive an email that you can personalize and easily send to your legislators to urge support for this important legislation. If you're not yet signed up, just visit our Advocacy Action Center on acep.org and use that to send your own note. Last Tuesday, Representative Mike Thompson of California reintroduced the ACEP-supported Bipartisan Background Checks Act of 2021, or HR 8, legislation to require background checks on all firearm sales, with certain exceptions such as gifts and loans between family members, law enforcement exemptions for official duties, and others. The legislation shares the same bill number as a previous version introduced during the 116th Congress, which successfully passed the House of Representatives but was not ever considered by the Senate. Representative Thompson, chairman of the House Gun Violence Prevention Task Force, was joined by Representatives Jerry Nadler, Fred Upton, Sheila Jackson-Lee, Christopher Smith, Robin Kelly, Brian Fitzpatrick, and Lucy McBath as original sponsors of the legislation. Companion legislation was introduced in the Senate by Senator Chris Murphy of Connecticut, the Background Check Expansion Act. However, while the bill is co-sponsored by nearly every Democratic senator and is bipartisan in the House, it currently has no Republican co-sponsors in the Senate. The bill requires a federal background check to be completed for any transfer or sale of a firearm, with exceptions, as I noted earlier, and is consistent with ACEP policy on firearm safety and injury prevention. The legislation does not establish a federal registry of firearms. ACEP will continue to monitor activity on this bill as it moves through the legislative process. We are also pleased to see a bill introduced by Emergency Physician Representative Raul Ruiz of California that addresses boarding challenges by providing grants that will help encourage warm handoffs for patients under psychiatric care. ACEP is supporting this legislation as well. Congress is currently reviewing the details of what should become the most comprehensive COVID relief bill to date. After Senator Ron Johnson of Wisconsin requested that the nearly 630-page COVID relief package be read out loud in its entirety last week, the U.S. Senate voted over the weekend to pass it. The House is likely to pass the historic $1.9 trillion relief package today. House Speaker Nancy Pelosi has called the package remarkable and transformative, while it contains many measures that have no Republican support. The bill includes a wide variety of provisions, including increased funding for vaccine production and distribution, aid to states and local governments, COVID-19 testing, as well as an ACEP priority based on the Lorna Breen Healthcare Provider Protection Act. This provision delivers a total of $140 million in grant and education campaign funding, $80 million for mental health and behavioral health training for healthcare professionals, other healthcare providers, and first responders, $20 million for an education and awareness campaign encouraging healthy work conditions and use of mental and behavioral health services by healthcare professionals, and $40 million for healthcare providers to promote mental and behavioral health. Part of the COVID relief provisions also include an expiration of the Sequester Moratorium. ACEP is monitoring this closely because it could lead to a 2% cut in Medicare reimbursements. We're continuing to explore avenues to mitigate or offset this provision, which is unfortunately likely to go into effect at the end of the month. Some of the amendments offered to the COVID relief bill in the Senate included a vote on increasing the minimum wage, whether undocumented immigrants may receive stimulus checks, and lowering the amount of weekly federal unemployment benefits. Following consideration of these items this weekend, the Senate narrowly approved the measure by a vote of only 50 to 49. The House is now poised to pass the modified COVID relief package sometime today, and will send it to President Biden for a signature and enactment into law. Several administration leadership appointments are close to being confirmed, and there are promising developments in ACEP's efforts to prevent workplace violence. Last Wednesday, the Senate Finance Committee split evenly along party lines with a 14 to 14 vote on whether to advance Javier Becerra for Secretary of the U.S. Department for Health and Human Services. Becerra is the first of President Joe Biden's cabinet nominees not to be favorably reported out of committee, which will force Majority Leader Chuck Schumer to bring up a motion to discharge his nomination and hold an additional 4 hours of debate before a confirmation vote can be held. Everyone nominated for a leadership role does not sail through. Senator Joe Manchin has yet to say whether he will support Javier Becerra. The nominee continues to face tough questions from Republicans about his experience in public health, his views on abortion, and lawsuits he filed as Attorney General of California. Meanwhile, the Senate Health Committee will hold a March 17th vote on advancing the nominations of Vivek Murthy for Surgeon General and Rachel Levine, who Biden tapped to lead HHS's public health work. Both are expected to play a prominent role in President Biden's pandemic response efforts if confirmed. Previously, Murthy was Surgeon General under Obama, and Levine is currently Pennsylvania's health secretary. Both experts are expected to confront systemic health issues that are important to emergency physicians and patients, ranging from opioid use disorders to COVID vaccine hesitancy and more. There are still several prominent posts that have not been confirmed, including the FDA chief, which hasn't even actually been nominated. But we'll continue to monitor leadership and staffing updates that impact emergency physicians. Meanwhile, addressing violence in the ED is a top advocacy priority, and important changes are being discussed at the federal regulatory level. In addition to the recent legislation that I updated on earlier, last year, ACEP and the Emergency Nurses Association, or ENA, were part of an action team sponsored by the National Quality Forum that included 27 experts and recognized leaders from the private and public sector committed to improving the safety of the healthcare workforce. The action team was able to identify and propose ways to overcome key barriers to appropriately responding to and reporting violent incidents in healthcare settings and preventing future ones from occurring. The work of the action team culminated with the release of an issue brief that is available to download on the ACEP Regs and Eggs blog. The brief includes specific sets of priority challenges for policymakers and other stakeholders to address. We can all be proud of these policy victories, but we are far from finished. ACEP will continue calling for national standards to ensure that all healthcare workers and patients are properly protected. ACEP has repeatedly been in touch with OSHA about the creation of such standards, as directed in the recently reintroduced legislation that I updated on earlier. The Joint Commission, meanwhile, is currently developing new requirements for hospitals under its hospital accreditation program that specifically relate to workplace violence. These proposed requirements for hospitals include creating a workplace violence prevention program within each hospital that's led by a designated individual and developed by a multidisciplinary team, conducting an annual worksite analysis related to its workplace violence program, establishing processes for continually monitoring, internally reporting, and investigating violent episodes, and providing training, education, and resources for the prevention of workplace violence to leadership, staff, and licensed practitioners as appropriate to their roles and responsibilities. Incorporating requirements related to workplace violence into the Joint Commission's hospital accreditation program would be a great way to push hospitals to take more specific actions to protect healthcare workers and patients. This is also an example of how change can happen even without regulatory or legislative action. ACEP had an opportunity to comment on these proposed requirements through an online survey, and we look forward to seeing them finalized. The CDC updated its guidelines for safe behaviors following full vaccination earlier this week. For physicians, the CDC continues to share clinical resources related to vaccination administration, storage and handling, reporting, and patient education. The CDC's guidance for fully vaccinated patients has been posted on their website. And in summary, it states that if you've been fully vaccinated, you can gather indoors with fully vaccinated people without wearing a mask. You can gather indoors with unvaccinated people from one other household, for example, visiting with relatives who all live together, without masks, unless any of those people or anyone they live with has an increased risk for severe illness from COVID-19. If you've been around someone who has COVID-19, you do not need to stay away from others or get tested unless you have symptoms. However, if you live in a group setting like a correctional or detention facility or group home and are around someone who has COVID-19, you should still stay away from others for 14 days and get tested, even if you don't have symptoms. People are considered fully vaccinated 2 weeks after their second dose in a 2-dose series, like with Pfizer or Moderna vaccines, or 2 weeks after a single dose vaccine, like Johnson & Johnson's vaccine. If it has been less than 2 weeks since your shot, or if you still need to get your second dose, you are not fully protected, and patients should keep taking all prevention steps until fully vaccinated. That wraps up this week's Capitol Minute. As a reminder, this episode and all others are available at acep.org/Capitol Minute. Now I'll be happy to take your questions. Remember, you can submit them using the Q&A feature of Zoom on the bottom of your screen. All right, here's our first question. Between the X waiver, physician mental health, and many other developments, ACEP is certainly making an impact. What does this say about ACEP leadership and strength of physician advocacy on the Hill today? It's a good question. No, I think this shows that if you have a focused advocacy strategy and a bit of luck, you really can make an impact and secure action on our priorities. I mean, a lot of work and moving parts go into this. Our lobbyists have great relationships on the Hill that they continue to cultivate, and they've been able to stay on top of those even in the middle of the pandemic, where we haven't been able to meet with legislators or their staff in person for just over a year now. And that relationship building without the kind of in-person touch can be incredibly challenging. So I think it speaks kind of highly of both the lobbyists and all the staffers working on the Hill on how committed they are to keeping things moving, even in the face of all the challenges we've had, that they've been able to make this work. So I think it's really important to keep that up. In terms of physician advocacy overall on the Hill, I think that has also continued. I would say that their receptivity by the Hill on our issues sort of depends issue to issue. Certainly anything COVID related, or what we like to call the white hat issues, where things for that help patients, or for example the provider mental health bill that we worked on, and the workplace violence one, there's a lot of sympathy and I think willingness to try and move things for us on the Hill. I think in terms of reimbursement related issues, there's a little bit of physician fatigue that we've noticed with congressional offices, even ones that are usually very supportive and helpful to us. And I think a lot of that comes from, it took 2 years really of surprise billing legislation ton of work on the Hill and hearing from a ton of physician groups over and over again on that, to that finally concluded at the end of the year. In the middle of all that, we had to advocate heavily, several specialties, including ACEP did, to stop really damaging E&M cuts that were coming, which could have been up to 9% for emergency medicine. Other specialties had similar high percentages. So again, the Hill heard from a lot of physician groups about needing more money and Medicare cuts and surprise billing. And so now with this Sequester 2% cut that's coming, I think it's really hard to make a dent and kind of be heard on that, because from Congress's perspective, they've already helped us. They helped us at the end of the year with surprise billing. They helped us at the end of the year with the E&M cuts. So they're kind of done on our payment issues, unfortunately. So that doesn't mean we've stopped talking about it at all. We continue to hit that message quite heavily, and we are hitting them hard with the Sequester discussions, but it does mean that it's a little harder to get through to them, and you may not see action. By the way, I just saw an update come up on my screen that the House did just pass the COVID relief package, so we can expect that to go to President Biden's desk quite soon and be passed into law. So that's the update, and I can actually see what the we have any details of the vote. So the bill passed 220 to 211 votes, mostly, entirely party line, no Republican support, and one Democrat, Maine's Representative Jared Golden, voted against the bill. So that's the final numbers on that. Another question has come in. Any idea what we can expect from OSHA with respect to a workplace standard that addresses violent incidents? It seems very hard to create anything that applies neatly to all the different work environments. So OSHA has been working on this standard for years. I don't remember the number of years, but it might be as close to like 10 years. And I think that is probably because it is so hard to create something that applies neatly to all different work environments. So I haven't been directly involved in the conversations. ACEP's Director of Regulatory Affairs, Jeff Davis, has. So I'm not quite as familiar at where OSHA has been sort of hinting at what types of things it could include in the standard. But if I had to guess, I would guess that it probably includes some things like similar to what the Joint Commission is doing with its accreditation standard. Things that the hospital or the employer, depending on the workplace environment, has to do in order to ensure the safety of employees or to correctly address or sufficiently address an incident of violence. So in terms of, I think, follow up and probably making sure that there's a process in place to look at preventing it in the future. And just making sure there's some sort of system in place to keep track of it and plan for violent incidents as well. So it'll remain to be seen what's happening with that. Another thing that OSHA is working on that we talked about, I think, a couple of weeks ago is what's called an emergency temporary standard, an ETS, for COVID-19 workplace protections. And so that is expected, it's due to come out by March 15th under an executive order from President Biden. So we're expecting that, as early as this Friday, but probably more likely very early next week. We'll see that on Monday, obviously. So we'll definitely be updating you on that. So another question coming in. Our progress on physician mental health is so important. What are the next steps? Is there any indication that the state level issues, licensing and credentialing, for example, are being sufficiently addressed? So one of the important parts of the Dr. Lorna Breen bill, and then also what just passed under the COVID-19 relief package, is this study to identify barriers to physicians and other healthcare providers accessing mental health and other resources against burnout. And we know that the licensing and credentialing are two key barriers. It's a little harder to address those in federal law. Federal law doesn't have direct jurisdiction over those things. Licensing is at the state level, but we're hoping that the standard the study, excuse me, will identify those as barriers and draw a lot of attention to them, and really provide a good state-by-state accounting of which do have some of these really damaging questions as part of their licensure process. We've tried to inventory what state asks what, but it's pretty hard to access that information, because you can really only see the questions if you're a physician, who's up for license renewal. Some states you can kind of see it a little more easily. Other states you have to be a physician up for licensure renewal to even see the questions asked. So it's pretty difficult for us to track that. I spoke to a reporter who was very enterprising, and she'd gotten a little further, but she was also hitting a lot of the same roadblocks. So our hope is that this study will identify that. And I think while they can't change what's happening at the state level, just having each state identified that is being problematic in this area will really help advocacy. And I think we'll see a lot faster action at the state level to change that once it's out. Another question, firearm injury prevention is important while gun laws are certainly controversial. Can you explain how ACEP decides to get involved in these types of policy conversations? No, that's a good question. One thing, especially on this issue, but most other issues, our policy position is guided by if we have any existing resolutions or ACEP policy on that issue. That definitely helps inform what we do advocacy-wise. And in the case of firearms, we do have a policy that came out of a resolution passed by the ACEP Council, which is obviously made up of physicians, emergency physicians from across the country, and are really a good representative sample of our members. And so there was a resolution that was passed by council that was turned into a policy by the ACEP board. And that has guided pretty closely our advocacy on this issue. And that resolution and policy do include supporting universal background checks. Other things that go into ACEP's decisions on how to get involved is, is it bipartisan? We know that we have members from across the aisle, like from both political parties and others. So we, I think on an issue that's a little bit more divided amongst our membership along party lines, if it's bipartisan legislation, then certainly I think that's a little bit more in line with being representative of the whole membership. And so that's definitely something we take into consideration. It's not going to be the only factor. And sometimes if something is like a huge priority in terms of how it impacts emergency physicians' liveliness, sometimes it's not going to be bipartisan, and we'll still be supporting it just for other strategic reasons. But that's a big factor, at least in this type of legislation. I think we have another question. Can you explain the Sequester Moratorium expiration? How did that come about, and how will that impact emergency physicians? So sequestration was an overall thing that was a budget maneuver, essentially. I don't remember how many years ago it was. I'd like to say 5, but who knows? A lot has happened since then. That was put into effect to help balance the federal deficit. And it included a cut to Medicare reimbursement of 2%. And that has been sort of put off a couple times. Most recently was last year was when COVID hit. It was supposed to have gone into effect, but because of the impact of COVID and everything going on, Congress took action to delay it as long as the public health emergency was in effect, or it was due to end at the end of March. I think it was whichever came first. And so now that time frame is up, unfortunately, and so we've tried to get it further delayed while the public health emergency is in effect, but it's getting pretty difficult to do that. There's not a lot of receptivity on the Hill. To them, 2% is nothing, whereas we all know 2% is actually quite a bit on Medicare reimbursement. So this is a big deal, and really just comes on the back of effectively physicians haven't gotten a pay raise in Medicare once you account for inflation in probably 20 years. So this is still a big deal. And so that's how it came about. It'll impact emergency physicians as a 2% haircut on any Medicare reimbursement, unfortunately. And so that's why we're trying to stop it. I think we have time for one last question, if there is one coming in. Yep, here we go. I've heard a lot about action alerts. Do these truly make a difference to elected officials, and how can I send mine? So they actually really do. So for those of you who don't know, an action alert is we ACEP will send out to usually to our 911 network, which is ACEP members who have opted in to be part of our kind of advocacy action team. But occasionally we'll send them to all members when it's a really big issue for emergency medicine. And what it is we just let you know that a certain piece of legislation is either up for a vote or needs to come up for a vote and needs Congress to hear from you that this is a really big deal to you. And then we ask you to send an email to your member of Congress or members of Congress, which includes the Senate as well, through the system. And it's super easy. You just click on a link, fill in your information. The next time you probably won't need to fill in your information because it'll be automatically populated. And then you can, there'll be an email pre-written for you, but you can tailor it if you want to share your own unique story on whatever that particular issue is. So for example, on the workplace violence bill, obviously it would be helpful if you could include an anecdote of when you or someone in your emergency department has faced violence from patients or family members and how that impacted everybody and the care you were able to provide. And then you click send, and on the elected official side, their offices will tally those up along with phone calls that they get. It only counts if you're a constituent. So when you see kind of calls to action to call a member of Congress that you do not live in their district, so if you hear if there's something going on in the news that you're super opposed to, and you hear about a member of Congress in another state across the country who's leading the charge on it, you could call their office, but you're not actually going to make any difference because they ignore the calls unless they're from a constituent. Same thing with the email. So there's really no point. What does make a difference is marshaling any of their constituents. What they do is, so they'll tally up how many of their constituents are on each side of a particular issue that might be coming up for a vote. And that will help direct what decision they make. So if they hear from 3,000 emergency physicians in their state, if it's a senator, let's say, calling for a certain vote on something, and they only hear from 50 other constituents that want the opposite vote on that, they will most likely listen to all those emergency physicians. So it really is important. We have updated our Advocacy Action Center. So it's on acep.org. Click on that advocacy tab that's on the top right side of your screen, and you'll see what current action alerts we have out there. So you don't have to wait to get an email. You can just check in and take action on any that you see that are important to you. And then you can also join our 911 network, where in addition to getting alert emails, you'll also get our weekly update on what's happening in DC, both on the regulatory and legislative side. Just a quick little summary of things that are relevant to emergency medicine. So that is it for today. Thank you again for joining us, and we'll see you in 2 weeks, same time, same place.